Good morning, everyone. This is Raquel here at the COE, and with me I have Dr. Amina Alio and Pam Whitcomb. Thank you for joining us for this webinar. We will be presenting the role of CHWs in addressing preconception and interconception health, and we'll be presenting some of the background on pre-interconception care, but also really focusing on what can CHWs do in the field. So we'll provide some recommendation and so best practices, and hopefully there's time at the end to hear from you, the community health workers, on what has been successful and what has been challenging for you in doing this work. So I will pass it over to Dr. Alio.
Good morning, everyone. As Raquel mentioned, we're talking about pre- and interconception care. I'm using the CDC recommendations for pre- and interconception care to sort of frame this webinar. And then as we go through it, we will discuss the role of the community health worker, or actually anyone who works with the clients in the community. So it could also be home visitors. So the goal is to understand the importance and explore the role of CHWs, as I mentioned. And I'd like to start by defining pre- and interconception care. So this is just a longitudinal timeline, if you want, of a portion of the reproductive life of a woman. So we have before pregnancy, then we have conception. And after that, we have the pregnancy time and then the delivery. And we have the short postpartum period and then the lapse of time between the next pregnancy. So preconception and interconception are the two periods before conception and in between pregnancies. So really the stages we're looking at are around the age of 15 to 55. Of course, we know that there are younger women that give birth, just that there are a few older women who also have given birth. But this is the average in general. So preconception is the time before a woman gets pregnant, as we mentioned, and in the context of maternal health, it refers to a woman's health status and any risks that she might encounter before her first pregnancy and shortly before any pregnancy. So it's been used either as the time right before pregnancy or any period before pregnancy. So you might hear the terms, but either way it means the time before pregnancy. As for interconception, as we mentioned, is a time between pregnancies. So the minimum advised age between pregnancies is 18 months from one delivery to the start of the next pregnancy. But I have seen it reported as 24 months between one delivery to the next delivery, which I assume includes the pregnancy period. So the point is to have a good around 18 months before pregnancy for the woman to recuperate from the first delivery. So overall, when we talk about preconception and interconception care, it's referring to all these interventions that are put in place to help improve the health of women before they get pregnant. For example, if a woman had high blood pressure, the preconception or interconception interventions could focus on making sure she has access to healthcare and gets treated for the high blood pressure. These interventions are also to help women change any of their risk behaviors, such as smoking, for example, or help them reduce some of the social risks, such as domestic violence, lack of housing, or any basic resources that they might need to ensure their optimal health and get ready for the pregnancy. Sometimes there are issues that need to be prevented. For example, making sure that the women obtain early screenings or vaccinations. And other times it's about management of more chronic health condition. For example, diabetes. If a woman has diabetes, she may need help not just getting medication, but also managing the treatment and adhering to diet or whatever it is the recommendations are from the physician. So a community health worker really has an important role in these interventions before and between pregnancies, because they are the ones that establish a relationship with the clients and help the women take the first step towards taking care of their health and preparing for a healthy future pregnancy. So this is a quote from the Institute of Medicine. So one of the best protections available against low birth weight and other poor pregnancy outcomes is to have a woman plan for pregnancy and enter pregnancy in good health with few risk factors, at least as few as possible, and really be informed about their reproductive health as well as their general health. So if a woman can effectively plan her pregnancies with the help and guidance of a CHW, she can be more informed and receive the guidance needed to reduce her risk and basically take control of her reproductive health. So women who are healthy before and between pregnancies have better outcomes for themselves and for their babies. Obviously, we know that based on the research findings and our own experiences. Just as those who become pregnant too soon after pregnancy or soon after delivery might have higher risks of poor birth outcomes, such as low birth weight, premature birth, or the baby being too small for his or her gestational age. So preconception and interconception care interventions help to reduce these risks and as well as reduce unintended pregnancies and make sure that all pregnancy are prepared for and planned. So with the disparities that exist, both by socioeconomic status and by race ethnicity, among the women that we work with, especially for African Americans, when you compare them to Caucasians, preconception and interconception care really become important for these communities. If you think about the health equity approach, it's important for making sure that these disparities in pregnancy outcomes are reduced. And when we talk about using a health equity approach, we mean that we meet every woman at the point of her need. So some women need more help than others. So assistance should be distributed according to the need of the individual woman or the individual communities. This would be the best way to improve health in high community communities with high needs, and make sure that we reduce disparities. So again, the role of the community health worker or the home visitor would be important in making sure that this process of health equity happens, and we not only identify client needs, but that we work with each one based on her own needs. So after this general introduction, we're going to go through the key elements of pre and interconception care. And as we go through it, we'll talk about, again, the role of the community health worker. So in general, the key recommendations are to look at reproductive life plan, medical conditions, screening, nutrition, weight, any psychological or social issues, mental health, well-being, and substance abuse or any type of barrier to access to care. So these are recommended issues that community health workers should be aware of, these CHWs can really help improve these areas among women that they serve. So it's not the job of a community health worker to screen or recognize any disease or any health condition, but community health workers can still play an important role in providing information, any referrals needed, support, encouragement, anything needed so that women can follow through with their health and their social issues. Anything that can come between a woman and optimal health and well-being before she gets pregnant. So we're going to spend time looking at each one of these recommendations throughout the rest of the webinar. So making sure clients have a reproductive life plan is a very important part of the pre- and interconception stage. So when a community health worker discusses developing a plan with her clients, they're helping to ensure that pregnancies are planned and intended, and that the woman works on being as healthy as possible while she prepares to become pregnant. So, of course, discussing a reproductive life plan can be a sensitive issue for some vulnerable women or women of color or women from particular cultures. So it's important that the CHWs address the issue with sensitivity and a non-judgmental attitude. CHW can begin the conversation by finding out the woman's desires as far as having children. Does she want to have children soon in the future? When would she ideally like to have the baby? How can the CHW help to achieve this goal? And based on the responses of the clients, the CHW can provide information on different types of contraception, or at least prepare the client to discuss these issues and bring up the topic with their healthcare provider so that they can guide her on what might be best for her as she plans for her pregnancy. So preparing women with this information and questions for their physician can really be empowering and helpful. So the CDC has a really good worksheet that CHW could use to help women make a reproductive life plan. So I know that there are many out there, and different programs may have, you may have some that you use already, but just in case you wanted another example, the worksheet, I provided the website if you would like to take a look. Excuse me. So there are types of questions that the CHWs could ask their clients, and this is just one model. It's actually used by healthcare providers during visits, but they don't always use it. So we found that it's also very applicable to the CHW conversations with the clients. So do you hope to have any more children? How many would you like to have? How much time in between, etc. So this is just a list of questions that this model presents. So if we look at the direction of the advice and information a CHW can provide, it would depend on whether or not the client desires children or not. So if the question is, do you wish to have more children? If the woman said, no, I do not desire any children or any more children, then the CHW knows how to approach it. That the plan would be primarily talking about long-acting, reversible or permanent contraception options. So it would be important to address any barriers to the women obtaining or using the contraception. Since CHWs do not provide a contraception, of course, they would need to be sure that client has access to healthcare, that she can obtain contraception advice from a healthcare provider, and that she is well informed about her options and ready to discuss it with the provider. There might be other potential barriers, which might be not knowing where to go to obtain contraception, not having transportation, having any fears or concerns about contraception in general, or there might be other financial, social, or cultural issues. So even if the woman does not plan on having any more children, it's still important for her to have a healthy lifestyle and address any behaviors that might negatively affect her health. But at least if the CHW knows this ahead of time, then she can work with the client towards their goal. So there's the scenario where the client wishes to have children, but later. So a similar conversation would take place regarding the reproductive life plan. But for this instance, the contraception information would focus more on reversible contraception, maybe reversible longer-term contraception. And similarly to the first case, the CHW would address any barriers to accessing contraception or being able to use it properly. So in this case, there would be emphasis on supporting healthy lifestyles and behavior, not just for the woman, but also for the baby she plans to have in the future. So another scenario is for women who want to be pregnant, pretty soon, within the next few years, next 5 years or less. And in this case, the conversation would be just as previously mentioned, but the contraception would be more short-term. And really, there would be a greater urgency to ensure that the woman is healthy, at least as healthy as possible for the pregnancy. And making sure that she has access to the right health care and that all the barriers are removed so she can access the proper health care, especially when it comes to contraception. So in addition to accessing contraception and having a reproductive life plan, I wanted to point out that the CHWs should be aware of various risk factors of pre- and interconception health. The age of the mother is important to consider when discussing the reproductive life plan. We know that research has shown that the younger the woman is, we're talking adolescents, 17, 16, 15 and younger, or if the woman is over 55, the higher the risk. So really young women and much older women have higher risks. So the CDC does mention that starting at age 35, the risk starts to increase for women. So it's just important to keep that in mind when working with women of those ages. And in the case of the woman being, let's say 42, for example, it would be important to refer her to preconception counseling. And that should be more encouraged, especially in this situation, excuse me. So this is just a figure to represent what we just talked about. So the curved line just shows the risk. So the higher risks are among younger than 15 and 55 and above. But you can see that from age 35, the risks start to increase for women. So the optimal age is in the 20s and early 30s. But as we know, there are many women who have children after the age of 35. So the key is really to just be aware of it and pay attention to potential risk factors associated. So there are many medical conditions that can affect the health of women as they get ready for pregnancy or for their next pregnancy. So when addressing preconception and interconception health, the CHW would also have the important task of working with women to identify any existing conditions. So meaning any conditions that the client has been told by a physician that she has. Maybe she's been told that she has diabetes. In that case, making sure she has access to healthcare, whether it's health insurance or access to a health provider. And the CHW would direct her to the appropriate healthcare providers or healthcare clinic or center, for example. So the important point here is that CHW should be aware of some of the potential conditions that might impact future pregnancies, such as diabetes, asthma, sexually transmitted infections, high blood pressure, and so on. So it would be, again, it's not the job of the community health worker to diagnose or have to learn all of these, but really to encourage clients to get screened and test for any potential health condition that may need treatment. So either they already know about a health condition, or they would need to be screened just to be sure that nothing is wrong and that all is well. And if something is diagnosed, that they would be able to treat it before they become pregnant. So, excuse me again. So some of these health conditions or screenings would be vaccinations, for example. We don't always think about vaccinations, but the CD does make recommendations for some vaccines for women in the pre and interconception stages. So I'm providing the website for more information, but this is just a snapshot of what the website presents. So it has the type of vaccine, and it has before pregnancy, during pregnancy, and after pregnancy. So I'm just showing you a little bit on the column for before pregnancy. So again, it's just being aware that it's important to be up to date on vaccinations and encourage women to discuss it with their providers in case they need something basic for prevention. So as far as identifying and addressing medical conditions, we know that heart disease increases the risk of many conditions for pregnancy, especially. Stroke, serious threat to women include diabetes, respiratory diseases, osteoporosis, etc. But it's not just the woman's health, it's also impacting the infant's health. And it could be a very preventable cause of prematurity. So if we're aware of these conditions and we treat them or we try to prevent them, then that would help ensure that infants have a better chance of being born healthy. So another one is dental preventive care. I think I went backwards on the slide, so I apologize. So the slide that you're looking at now, I believe, is talking about dental health. So we're talking about something that's sometimes, actually quite often ignored in preconception and interconception healthcare recommendations. But we've seen much connection with a lot of the issues that I mentioned. And also it's been tied to premature births and especially a lot of respiratory diseases, also cancers of the mouth and periodontal related cancers. So the key is to make sure that dental health is included in the discussions about being healthy prior to pregnancy. So another important recommendation that many of us have heard and that we all know about is the importance of folic acid. So we know that folic acid is a vitamin and that helps prevent major birth defects of the baby's brain and the baby's spine as well. So it's recommended that at least 1 month before pregnancy, at the very least, that women should start taking folic acid. So the earlier, the better. But even if they take it just 1 month before, we can see improvements on the baby's health. So again, the earlier, the better. And just so you might want to know, that also helps your skin, your hair, your nails. So organs that make new cells every day. So it's important to me as a woman, and I'm sure it is to many of us. But especially for preconception and interconception health, it's extremely important for the health of the baby. And this is an overall recommendation for women. So the CHW are well placed to begin a discussion of the importance of this vitamin and encourage women to get it, to start taking it as early as possible. So because this is an over-the-counter vitamin, CHWs can actually provide information about where to get it and how much is recommended. So it's 40 well, just remember the MCGs, micrograms. So look for 400, I'm sorry, not 40. So 400 micrograms per day, and you can easily check it on the labels of vitamin bottles or multivitamins. All of them, if they contain folic acid, will have the amount, and it will also have the percent of the daily value. So as long as the vitamin they're taking says either 400 micrograms or 100% of daily value of folic acid, then that would be great for the woman to start taking. And also, it's some cereals actually have folic acid in them. So again, it's just simply checking the label and looking at the percent daily value in the serving. So as long as it's 100% or 400 micrograms per day, then that would work. And of course, when the woman goes for preconception appointments or general women visits with her physician, I'm sure that would be recommended, hopefully. But again, physicians may not know that the woman is planning to get pregnant if she's just there for a well woman visit. The topics does not always come up. But again, it's important to know that this has been tested with CHWs. I saw a study that talked about promotora's role and how just talking about folic acid to the women they work with, they actually saw an improvement in the number of women who actually took the vitamin supplement. And they all reported that they were taking it because the promotora had recommended it and talked about it. So we do know that this is something that the community health workers can easily have an impact upon, and something that would be important for the woman and the baby. So another important issue as far as health is concerned and pre and interconception health, CHWs can talk about the importance of family history, and that they need to be sure they share this with their provider. Usually health providers will take family history, but again, the women can take control, and the CHWs can empower the women to really bring up these issues. Conditions such as sickle cell disease or multiple miscarriages in the family or any infant deaths, any kind of genetic condition or birth defects would be important for the physician to know. Similarly, they should also share their own reproductive history so that any issues can be prevented for the next pregnancy. So before we move on, I just want to summarize the potential roles for CHWs when we talk about medical issues covered so far. So really the primary role is to assist with the development of reproductive life plan, provide information about contraception, and any kind of care within that period, such as taking folic acid, identifying and addressing health conditions. So it's really providing information, encouraging women to get checked out and to follow treatment as recommended. So CHWs can also encourage not just preventive but curative health, but especially help women address any barriers to care and helping them get ready to discuss issues with their physician. So, and as for chronic existing conditions, CHWs can help clients develop sort of a management plan and maintain it. So we'll move on to more behavioral issues. So when it comes to behavioral issues such as reaching and maintaining healthy weight, CHWs can be instrumental in providing support, providing information, making referrals. So informing clients of the potential impact of unhealthy weight, not only on her own health, but on her baby's development, is an important first step for CHWs. So research has definitely shown that women who are overweight or have obesity have a higher risk for conditions such as heart disease, type 2 diabetes, and certain cancers. And the effect on the pregnancy can also be detrimental and can lead to different complications during pregnancy. But also, we need to be aware that women who are underweight have increased risk of pregnancy outcomes such as preterm birth, low birth weight, growth restrictions, and birth defects. So in the populations we serve, underweight may not be an issue, but it's still important to be aware of it. Talking about healthy weight, CHWs can provide information on how to maintain healthy weight through healthy eating, regular physical exercise, encourage women to discuss their issue with the healthcare provider if it's really a big problem for them. So the physician may have some suggestions for how to reach the ideal weight before they get pregnant. As for psychological and social factors that CHW should be aware of course, is intimate partner violence, lack of social support, high stress and anxiety, inadequate resources. All of these are directly tied to poor health outcomes. So the CHWs, again, can make referrals necessary to help women obtain the assistance they may need. And I know that there's much training on many of these issues separately. But overall, when we talk about preconception and interconception care, it's identifying the social issues and referring clients to the appropriate agency. For mental health, living in poverty and living within high poverty communities can really bring about much anxiety and stress. So we all feel sad or anxious or stressed at different times in life. But when we talk about mental health issues, we're referring to feelings of stress and anxiety that don't go away and that actually interfere with day-to-day activities. So these should be identified and addressed. And CHWs can raise awareness of the negative effects of mental health issues and refer them for care. CHWs can also provide general information of positive coping mechanisms or stress reduction activities. So mental health, again, is attached, comes along with a lot of stigma attached to it. So because of CHW's knowledge of the community, they are well placed to speak with women about some of these issues and the need to get help when needed. And not only for themselves, again, but because it does impact women's health, which then impacts their readiness for pregnancy and future pregnancy outcomes. So the use of illicit drugs, smoking, and alcohol abuse, of course, these are all very detrimental to pregnancy, especially during pregnancy. But CHWs can help communicate to clients that there's really no known safe amount of alcohol, for example. During pregnancy, it's recommended that no alcohol be consumed. But also, when women are trying to get pregnant, they should work on eliminating alcohol, especially if they're trying to get pregnant in the near future, because all types of alcohol are equally harmful. And when a pregnant woman drinks alcohol, so does her baby. And I'm saying that because if a woman drinks alcohol while she's sexually active, she may or may not effectively use the contraception that she's on, the birth control that she's on, and that could lead to unintended pregnancy. Or she can get pregnant and not realize it for a few weeks, and the baby is unwillingly exposed to a certain amount of alcohol or drugs or nicotine from smoke, etc. So, and speaking of smoke, we know that smoking tobacco is harmful to the baby. So are illicit drugs. So again, the issue here is, it's not, well, I'm not pregnant, so I don't need to worry about that. But that if women are intoxicated, that it can lead to poor choices, and we all know that that happens, poor choices that may lead to unintended pregnancy. But as I just mentioned, all of these can impact a pregnancy because it takes about 4 to 6 weeks for women to actually realize that they're pregnant. So that would be 4 to 6 weeks where women have been smoking or drinking or doing drugs and exposing their baby. So for women who are really, of course, everyone should reduce alcohol and not smoke and not do drugs, but especially for women who are trying to get pregnant in the near future, this would be important for them not to expose their baby and cause harm to the baby. So another issue to be aware of is that the environment clients live in, the homes they live in, the places they work or hang out at, all of these can potentially negatively impact them and future pregnancy outcomes. So a lot of environmental toxins are associated with birth defects, miscarriages, infertility, low birth weight, developmental disorders. And we're talking about environmental issues such as pesticide, which can be used in the home, in gardens, or for people who work in farms, for example. Radiation is harmful. So if anybody works in an X-ray lab, for example, or works near an X-ray lab, animal feces, or either working with animals, being around animals in unsanitary conditions. Lead is also a big problem, especially in the communities CHWs work in because of the paint and the age of the homes, the houses that are built when lead was still very high in the paint. And mercury also, we know that certain fish have high rates of mercury. So CHWs can help women consider their exposures and kind of pay attention to what they're being exposed to, and if possible, take the necessary precaution. And at the very least, they can tell their healthcare provider. And for that, the CHW would be important for ensuring that the women have access to healthcare and the healthcare provider. So in sum, as far as behavioral, social, environmental recommendations for preconception and interconception care, CHW's role varies from providing information on different issues all the way to referring clients for assistance, whether it's medical or social, and encouraging and supporting healthy behaviors. In summary, if we look overall at the potential role of CHW, identifying barriers to access to care is vital for ensuring clients' optimal preconception and interconception health. So this might include CHWs ensuring that they have health insurance, addressing social, cultural barriers to women getting or using contraception, or attending to any health issues during preconception and interconception care. Again, as we mentioned, it could just be transportation. It could be not knowing where to go for various care, or not having enough information, or any other social or cultural barriers. And I'm sure there are other barriers or issues that you've encountered that we have not named. So feel free to type them in if you think of others that you would like for us to discuss that I have not mentioned. So feel free to just type it in while we continue. So I wanted to bring up an important area that's been ignored also in women's reproductive health, is the importance of being aware that men also play a role in pre- and interconception health and in preparation for the baby. So it's important for women, but it's also important for men, because half of the baby's genetic genetic makeup, the genes are actually coming from the father. So it's important that they are also healthy so that the DNA transmitted to the baby is as healthy as possible. So biologically, it's important for them to also think about their health if they're planning to have children, if they're trying to get pregnant with their partner, for example. But from the social aspect, it's also helpful to the woman because together they can plan the pregnancy, together they can do a reproductive life plan, and they can help each other with improved health behavior, assuming the relationship is existing and going okay. So during preconception, interconception care, the partner, the male partner, could help with making sure that she goes to healthcare appointments, encouraging her to stop smoking, or he himself stopping smoking to not expose the potential new pregnancy to secondhand smoke, and just general support for each other. So I have a website that I'm going to show you in a minute that has more information. We don't have time to go through all of the issues. But really, most of the aspects of men pre- and interconception health is similar to women's health before pregnancy. So whenever possible, if the men are around or involved somehow, CHWs can encourage the involvement of these partners in the development of a reproductive life plan for the couple. It definitely works better if both of them are on the same page, as we know. It's also important for the couple to be aware of the male partner's family history because hereditary conditions could come from his side and could potentially be prevented or addressed early on, or it could be monitored during the pregnancy. Also, any existing mental or physical condition of the man should be addressed. And especially because there aren't many reproductive health programs for men in most communities, CHWs could be helpful by at least involving men in this process of pre- and interconception healthcare and planning. And also emphasize the importance of their role in the pregnancy planning process. And if there's any information that they can provide, pamphlets on how to get health insurance, or a provider list, or any type of community resource list that they might have. The CDC also has some pamphlets that can be used to just hand out to men during visits with clients. That can be shared with the men, or the women can actually share that with their partner when they are with them. So as much as possible, involving the men, or at least showing them that their role is important as well. So this is a website. There's the Men's Health Network that also has a lot on information for men. Maybe I should, if you want more information about it, I can send you several additional websites. But these are the CDC's general recommendation. And it also included a worksheet for men's reproductive life planning, which is, again, very similar to the women's. So the same could be used for both. So preconception health is really a precious gift to babies. It means that their parents took steps to get healthy before they got pregnant. And it means that these babies are less likely to be born too early, preterm. They're less likely to have low birth weight, and they're more likely to be born without birth defects or other disabling conditions. So really, preconception and interconception health gives baby the best gift of all, which is a chance at a healthy start in life. So knowing about the resources available to address pre- and interconception care-related needs is really important for CHW. So whether it's a list or pamphlets or anything, or through training or the agency providing information, they need to be aware of where to refer clients, what types of agencies provide what services in the community, what resources are available, and to meet the various client needs, whether it's social, mental health, dental care, or preconception counseling. So there are many, many other roles. This is just a summary of what we discussed. Assisting with the reproductive life planning, providing information in general, addressing barriers to care, assisting with referrals, management of health condition or healthy behaviors, encouraging and supporting women to have at least a well woman visit once a year, unless they have health condition that require more, of course, but at least one preventive visit a year. And empowering clients by preparing them with questions to ask their doctor has been really proven to be effective, and making sure that physicians are providing information that the women need. And also, just think about the men as well, if you encounter them, to provide information on the importance of their part in pregnancy and preparing for pregnancy. So I haven't seen any additional issues. Nobody has written, but again, we can talk about any other important tasks, roles, or any issues that I mentioned that you want to, that we can talk about more. But because you are on the ground, I would love to hear about any other ways that you've helped clients, or you could help clients with their preconception and interconception care needs. So I would love to hear more. What I shared with you is based on research, but I would love to hear what it's like on the ground. So if you'd love to share, that would be wonderful. As always, I know you hear this all the time, but feel free to actually speak to us. If not, I think someday somebody's going to do it, and I'm going to fall out of my chair. But otherwise, feel free to just type it in, and we'll discuss. So, any ways that you've helped clients with preconception and interconception care needs in the field, or anything else you want to mention, or questions?
So we'll give you a couple of minutes to think about this. You may be all sitting as a group if you want to unmute yourselves and talk about the work that you're doing and how you see your role as a CHW, or any additional activities that you could be doing based on what has been presented.
Have any of you discussed a reproductive life plan when the man or the partner or husband or boyfriend was around? I'm just curious if that's a process that you run into, and how you dealt with it. I'm just curious. Okay. Everybody's quiet today. Is this thing on? Or? Okay.
Right?
No,
you can also raise your hand and we can unmute you if you're having some difficulties with that.
I'm sure this is all review for most of you, but again, it's just a reminder and emphasis on a few things. All right, Raquel, it's on you.
Any successes with any specific preconception or interconception activities at your programs, or any challenges that you're experiencing when you're in the field, whether maybe doing some outreach to preconception women or finding interconception women? Tell me about the work that you're doing in this area. Any specific strategies you're using, whether in an urban or rural setting? Give you another minute, give you another opportunity here. Oh, great. Okay, so a comment here. We have low numbers of preconception women in general. It is one of our goals to find more preconception women. We have gone to multiple locations where teens are to try to get our information there. Could you say like where you're located?
So actually this is, yeah, you're in Utica. This is an overall issue in maternal and child health programs because they've been focused so much on pregnancy and postpartum and early childhood that it's recently that the focus has been more on the life course. So there's been a push for reaching out to women before they get pregnant, before they're even thinking about getting pregnant. I can see why you're quiet today because it has been, I've spoken with quite a few in Rochester, and it is challenging to try to recruit women who are not pregnant because these programs are usually targeted towards pregnant women. So just finding women in general that would need help with preconception and interconception would be, especially preconception, would be a little more challenging. And most of them would not be out there seeking preconception care assistance. So I definitely, I know that the programs here we have, it's definitely been an issue. So perhaps, one day we should talk about how do we do that? How do we actually reach out to preconception women? It's a little easier when interconception because you can start talking about it during the postpartum period. But for preconception, it's very, very difficult. So perhaps one day we can have a discussion, or if we're ever in person, we can talk about how to actually do this, look at successful programs, how they did it, and how to do that. So yeah, it's the same problem everywhere. So yeah, I was hoping some of you didn't have the problem, but it looks like it's universal. So. And I think it's really related to the change in the approach for maternal and child health that has gone, wider and including women who are not pregnant.
So is it that for the women that you're finding, is it that they already have had a birth and preconception doesn't apply to them? What?
They're usually not seeking care. Yeah.
Mm-hmm.
So if I'm not thinking about getting pregnant,
most are either pregnant or already have children. Right, exactly. So of the women you're finding, okay.
Yeah.
Mm-hmm.
So really targeting, and I know there are teen programs out there that target teenagers. So, but there might be younger women in their early 20s that have not yet had a child that should be thinking about it. So,
what about the community colleges in the area? Is that even a possible target?
For CHWs?
No, I mean for preconception women.
Oh, right. No.
Right. So
yeah, I don't think they want to go there.
I mean, see, someone mentioned after school programs, but even community centers and GED programs.
Yeah. Yeah. So the target would be younger women, and right. that's what makes 20s,
it. Even in the 20s. Mm-hmm.
Yeah. But the question is, are there programs out there already doing it? So we need to focus more on interconception, or is there a gap and we need to really push recruitment for that age groups? So, I mean, that's something, hopefully at the conference next week, perhaps we can discuss it. So,
any other comments or questions? Thank you for sharing this.
all right. So we have future webinars.
Well, we appreciate you listening in, and hopefully there has been a few takeaways that that can help you do this work at your community. Next week we're having our annual meeting. However, on May 23rd is our next webinar, and that's tobacco use and exposure in mothers and children. That's May 23rd, so please visit our website to register for that. And then at the end of the month, May 31st, we have a webinar on evidence-informed practice for community health workers to address intimate partner violence. So stay tuned, register for that if you have not already. Thank you all for being in today's webinar, and if there are additional questions or comments that maybe come up at the end after we end it here, please send it to our email address, which is mihcoe@urmc.rochester.edu. So thank you all. Talk to you soon. Bye-bye.